I would like to introduce to you today's speaker, Dr. Srinivas K. Rao. He has been my teacher in Shankar Netralaya, and in one word, if I had to introduce Sir, I would say he is absolutely a living legend in the field of anterior segment in ophthalmology. I requested him for his CV, and it was so long, but I have made it short a little bit, and I will read out to you because I want you to know that we have amongst us one of the very best in India. He will be talking about fungal keratitis today. Sir completed his MBBS in 1988, and he did his DNB in 2002, and he also did his FRCS also in the same 2002 year from Edinburgh. He has won the Muthuswamy Gold Medal for the best performance in the FRCS exam, other than many gold medals that he won during MBBS and post-graduation. He was a consultant at Shankar Netralaya, Chennai from 1991 to 2004. And then he was the professor at Department of Ophthalmology in the Chinese University of Hong Kong till 2006. And after that, now Sir has established the Darshan Eye Clinic and the Surgical Eye Center in Chennai, where he is the director till date. He is also the senior consultant at Apollo Hospital, Chennai. He is a visiting consultant at Madras Mission Hospital, Chennai. He is the head of the Cornea Services at Sunetra Eye Care Center at Kolkata. And he is the senior consultant and advisor for Shankara Eye Hospitals, Coimbatore. He is the senior consultant of Shankara Eye Hospital, Pamal, and honorary associate professor of the Chinese University of Hong Kong. He has done his specialized training at Los Angeles, Dallas, Boston, and New York. He trained for phacoemulsification in Calgary, Canada, and for LASIK in Minneapolis. He did his lamellar corneal surgical training at Rotterdam and keratoprosthesis surgery in Italy. He is a certified advanced IUL surgery and alpha core prosthesis and has been trained in epidemiology and biostatistics in California. He has published more than 182 papers in peer-reviewed journals. He has authored more than 20 chapters in books, and he is a reviewer of 10 peer-reviewed journals. What an honor it is for us to have Sir over here with us. And Sir got the Outstanding Service Award in the Prevention of Blindness from APAO. And he has received the IMA Oration Award in October 2006. He also got the Rustam Ranji Oration Gold Medal in 2008, and he got the IEOH Oration Medal 2009 and the Trivandrum Ophthalmic Club Oration in 2016. Sir, we are deeply honored and privileged by your presence, the time and effort that you have taken out to be with us today, sir. We also have with us Dr. Sagar Bhargav, who is a consultant at BBI Foundation, Kolkata, and he will be the moderator for today. So I'd like to request Dr. Srinivas K. Rao to please begin his presentation.
Okay, just to make sure that you can hear me and that my slide is up on the screen, if Manish can just say yes or no. Can you see the slide and can you hear me clearly?
Yeah, clear, sir. Your sound is clear. We can see the slide, sir.
Fine, I'm going to start then. First of all, Satyajit, thank you for having me with you, and good evening to everyone who's on this platform. I understand that this is a PG update, and hence I have tried to structure my talk and slides with a view on the exams as well. Basically, as far as the etymology of today's condition is concerned, we can use the term keratomycosis, but for the sake of uniformity, we tend to use the term either fungal or mycotic keratitis, because this becomes standard, and then you can also call it bacterial keratitis or viral keratitis or parasitic keratitis. So obviously, keratitis is any kind of inflammation in the cornea, and in the case of a fungus, there's an infective element to this inflammation as well. This entity was first described by Lieber in 1879. And as you can see from the pictures, there's a wide diversity of fungi in nature. And if you look at the genetic profiles, there is more than 1.5 million species of fungus that are present in the nature. However, from the point of view of today's interest, which is fungal keratitis, there's about 70 or 100 species which are known to infect the cornea and cause the problem that we are going to look at over the next 45 minutes or so. So basically, we first need to understand that fungi are harder to treat when they cause corneal infections than bacterial infections. And the reason for this is basically from the structure, and that is why I put up this particular slide. Bacteria are fairly primitive unicellular organisms which are prokaryotic, which means that they do not have a distinct nucleus or other organelles. They have a nuclear zone and they depend upon a host for their survival. Of interest, they can be of asexual reproduction and they can be motile because a lot of them have flagellae. And they are classified as what are called autotrophs, which means that they can develop their own source of energy, like by photosynthesis, and they can use proteins, sugars, and carbohydrates. If you compare this with fungi, fungi are more evolved, they are multicellular, and they are eukaryotic, which means there is a nucleus that they have, and they have cellular organelles, and therefore they are closer or resemble the human cells a little better than the bacteria. Can be sexual or sexual and sexually normal, and they can be independent of the host. They don't well except for nourishment. They are heterotrophs, meaning that they cannot make their own source of food, so they feed on dead and decaying matter, and that is why a host is required. And in the cornea, they tend to eat the necrotic cornea tissue, and they use carbs as their basic nourishment. Now, the last point on these two comparative columns is the most important. If we look at the cell wall structure of bacteria, they contain peptidoglycans. There's more of it in gram-positive and less of it in gram-negative bacteria.
Hello.
Cell wall contains chitin and ergosterol. And this is an important point. Fungi tend to resemble the human or the host cells more closely. And therefore, when you're using an antibiotic to destroy these organisms, you must make sure that this does not affect the host cell as well. And this difference in the structure of the cell wall, the chitin and ergosterol, is used to our advantage because in the human cell membranes, we have more of cholesterol. And therefore, most antifungals, as we shall see in the later slides, tend to target the ergosterol part of the cell membrane of the fungus. And by damaging that, we try and hurt the fungus. So this is an important point for you to remember. The classification of fungi in general is complex, but if we are limiting ourselves to those that are causing keratitis, then it becomes a little simpler. So essentially, fungi can be filamentous or they can be yeast forms. And I'm sure you know this. The filaments, by definition, are long, like filaments. They are the molds. They have branching. They may be septate or aseptate, as opposed to the yeasts, which are more globular. They are more unicellular. And the other difference is that the yeasts multiply by budding. They just hive off from each other, whereas the molds usually form spores. So if you look at the filaments, which are non-pigmented and septate, that is the column I put up here, and these contain the most common organisms that cause keratitis in the humans. This includes Fusarium, Aspergillus, Scerosporium, Bacillomyces, and Acremonium. So obviously, if you have non-pigmented septate filamentous fungi, you will also have pigmented filamentous septate fungi, and these are called the phaeoid organisms. And these are Bipolaris, Curvularia, Halophora, and Cladosporium. These are the septate, pigmented, and non-pigmented. You can also have the aseptate filaments, which are the zygomycetes, given here in blue, the mucor, the rhizopus, and the absidia. And I've clubbed them with the yeasts, which, as I said, are unicellular organisms. And you all know about the Candida and the Cryptococcus. We also have organisms that are called thermally dimorphic, which means that when you try and culture them, if you use a temperature of 30 degrees, they grow as yeasts. But if you lower the temperature to between 20 and 25, they will grow like molds. Now, these are the Paracoccidioides, the Coccidioides, the Sporothrix, the Blastomyces, and the Histoplasma. And the last column that we must remember is those of uncertain classification. And of these, the one of interest in keratitis is Pythium. Rhinosporidium can cause conjunctival infections. It does not cause corneal infections, and neither does pneumocystis. So if this looks a little bit more complicated, it's very simple to just remember one for each if you like. So there are filaments, there are yeasts, there are dimorphic organisms which are a bit of both, like I explained. Depending on the temperature, they will grow as one or the other. And there are those that are of uncertain etiology. The filaments are further divided into septate and non-septate. And the septate are further divided into pigmented and non-pigmented. Now, why is this important for us? Why should we remember the classification? So apart from the viva and the exams, there is a clinical relevance to knowing this as well. If we know which of these categories the infecting organism belongs to, it helps us to try and determine the best choice of antifungal antibiotic that we must use to get going with these. And it also helps us in determining the prognosis for that particular eye and cornea, depending on the organism that infects it. So some of the summaries that you can take home from this are that the commonest are the filamentous organisms, which are septate and which are non-pigmented. That is the fusarium, which is predominantly seen in South India, and the aspergillus, which is predominantly seen in North India. The third most common type of infecting fungus is the pigmented septate fungus, and this often has a poor prognosis, although initially we believed that pigmentation of the cornea meant that we could treat this easily. More reports now indicate that pigmented fungi tend to have a worse outcome. Now, these two, which form 97 to 98% of infections in India in the cornea, tend to occur in young, healthy adult males, and they are predominantly work-related trauma. As opposed to this, the third category, or yeast, often requires compromise, either in the host in the form of some HIV or tumors, lymphoma, or diabetes, which is uncontrolled, or in the ocular surface, where neurotrophy, or if you have a Stevens-Johnson, or if you have a bullous keratopathy. And these are the eyes in which the yeast can come in. The yeast also prefers temperate climates, so it is seen more in the West and in the developed world, whereas we see more of filamentous organisms. The dimorphic organisms, like I said, seldom cause keratitis. They can cause lid infections, episcleral and scleral infections. They can cause uveitis, and they can cause orbital infections, but they seldom affect the eye itself. And finally, we have, among the uncertain etiology, the newly described Pythium. More of it, and for certain reasons, it is very peculiar. And a lot of what we will talk about in general about fungal keratitis does not apply to this particular organism, and it is generally harder to manage. Now, when we look at the epidemiology of fungal keratitis, epidemiology, as you know from your SPM classes, is the distribution and determinants of disease in a given population in a given time period. We normally talk about prevalence, which is the spread of cases in a population at a particular point in time. And we also talk about incidence, which is the occurrence of new cases in the population over a defined time period. Now, this is important to know in order to put in perspective how important is fungal keratitis in the context of eye infections. Most of the data that we have regarding fungal keratitis, and which we still use to describe the prevalence in India, comes from a study that was done in 1993 in Madurai in South India by the Arvind group. And basically, in that study, they quoted a number of 1.3 people per 10,000 population having. Now, this data is still what we use in as far as India is concerned. And this infection rate was 10 times higher than what was prevalent in the US at that time. And I'm sure that difference still continues. So fungal keratitis is very common in India. We talk about a lot of reasons. We talk about the agrarian community. We talk about work-related injuries in the field. We talk about a humid, hot climate where the fungus can grow and so on and so forth. But whatever the reason, fungal infections are more common in India than in the West. Now, if we extrapolate these numbers to the overall population in the country, they came up with a number of roughly 8.4 lakh cases in India per year. This was in 1990. And this data probably still holds true. The next year, they did another study to find out how many of the corneal infections that were seen in the hospital were fungal and how many were bacterial. And they indicated roughly 50% of the infectious seen in the tertiary care hospital, which makes it a very important problem considering basically this number still holds good in more recent studies that have come out of L.V. Prasad and so on in more recent times. The other thing that we must remember that in studies, 2.9 to 6.6% of normal people with healthy ocular surfaces, when cultured, will show the presence of fungi. In one of these studies, when they went back to the same people after a couple of weeks and did the culture again, the fungi were not seen. So this leads us to believe that in a lot of our eyes, we have transient ocular or aerosol-related contamination of the ocular surface by fungi. And in general, most of us are safe and we don't have problems from these commensals because they cannot penetrate an intact epithelium, unlike some bacteria. So you and I are generally safe until we get an epithelial problem. So when we do have an infection, it is important when the patient presents to us that we recognize fungal keratitis. And how can we do that? This starts from the history itself. So if you have trauma by vegetable matter, we think in terms of a fungus first up, because the vegetable matter often contains a very high load of the fungus. And when the trauma breaks through the epithelium, then the fungus can get in. Until 2006, we generally believed that fungi were not a problem in contact lens users. We were more concerned about Pseudomonas, and the West was more concerned about Acanthamoeba. But in 2006, there was an epidemic or outbreak of Fusarium fungal keratitis in people who were using contact lenses with a solution made of a particular brand by a particular company. There was some formulation issue, and therefore these people developed in 2005 and 6 a bunch of infections in contact lens related situations, and therefore we now believe that fungi can also result from contact lens infections. Both in Africa and India, traditional medicine use has been associated with fungal infections in the cornea, and this is because extracts from dried leaves and herbs, they mix it in blood, breast milk or urine, and then they put it in the eye, and this increases the load of fungus that goes in. If there is steroid abuse on the ocular surface for some reason, if you have an ocular surface disorder like a Stevens-Johnson where your tears have dried up and you don't have the protective lysozyme and the other enzymes in the tears, or if you have a systemic immunocompromised state like I mentioned earlier, or uncontrolled diabetes, these are risk factors for fungal keratitis. You can also get clues from the duration of the disease when the patient presents to you, because bacterial infections tend to progress faster and patients often tend to report the disease. If a patient presents to you 1 week after the onset of a problem and says he has antibiotic for the last 5 or 6 days and he still has a progressive corneal infection, that could be a clue that this is a fungus because the antibiotic would have taken care of the bacterial component. There is a relative lack of pain. There is a relative lack of discharge in fungal infections, and it's a relatively quiet eye. And we generally say that unlike bacterial infections, in fungi, the symptoms are much lesser than the signs that you see on the cornea. In the bacteria, it is the opposite. The most important, of course, is the clinical features, and that is what I'll show you in the next slide. But remember that all of these features that I've talked about here generally apply in the early stages of a disease before the morphology and everything has changed. So what are the typical features of a fungal keratitis? The first is this kind of a dry, raised appearance. Most bacterial infections spread rapidly, cause collagen destruction, and therefore they have what is called a wet appearance. You see these hyphate edges at the edges of the infection, and that is typical of a fungal infection. You can see what are called satellite lesions, lesions that are just ahead of the main bulk of the stromal infection, and these satellite lesions are typical of fungus. And you can also see a cheesy hypopyon in many of these eyes. So these are typically what you will see when the patient presents. Later in the course of the disease, you can see it integrated posteriorly in the cornea. And here you can also see a wet appearance. And this is typically seen in patients who have abused steroids without knowledge of the fungus. They keep putting steroids in, and this changes the fungal patterns of development, and this can happen. You can also see a plaque on the surface of the cornea in many fungal infections. You can see pigmentation if it's a demataceous fungus. And sometimes you can see an immune ring, this kind of a faint haze surrounding the main body of the infiltrate. And this should typically not be called a vessely immune ring. That is because in a fungus, the immune ring is caused by the interaction of the careful to go in and interact the antigens that are coming to this ring. And if you remember your third year microbiology, on a Oosterlony plate, there is a diffusion of the antigen, there is a diffusion of the antibody, and is the reaction of the antigen and antibody which produces a similar ring, and that is typically what you should call a Wesley immune ring. So this is an immune ring, but because it's not antibody, but the immune cells that are causing it, we should just term it as an immune ring and not the Wesley ring. Now, when you see a patient like this, what are you going to do next? The first thing is to describe the finding, and in the exam, obviously, this is quite important, but so it is in practice as well. So obviously, we must take a photograph. This is important because medico-legally, if the patient later claims that he came to you with a very small infection and the treatment made him worse, then you can have something to your defense if you can show that he came with a picture like this with almost 2/3 of the cornea involved. If you don't have access to a photograph, even if you do have a photography device, if you're learning, it's important to make drawings. This drawing should be color-coded. It should mention the size of the infiltrate and all of the other features that you see. And you must also do side views, because this is where you can show the extent of infiltration in the stroma. You can show how much of corneal thinning there is, and this is important to do. This also improves your examination skill in the cornea, because if you know that you're going to have to come back and do a drawing, the mind will start looking at the vertical and the horizontal measurement, because you know you have to do an accurate drawing. It will look at the depth and so on. Otherwise, you just see it, you say there's corneal infiltrate, and you walk away. And these kind of detailed drawings are also important for follow-up, because you want to know when the patient comes back whether he's better, worse, or the same. And this is what will help you do that. Once you have this detailed, the next question is microbiology. When I go to meetings for corneal infections, a lot of private practitioners ask me how important is microbiology in managing infectious keratitis, because unlike institutes, having good access to microbiology in a private environment is extremely rare, because the amount of tissue that you can take from the cornea is very small, and most general microbiologists are not used to dealing with this kind of tissue. If you look at the literature, basically it says that identification of the causative organism in keratitis does not appear to be associated with significantly better outcomes. It also goes on to say that small, peripheral, primary corneal infiltrates with features of non-virulent bacterial pathogens may be treated without microbiology. The caveat here is the ophthalmologist should be and he must be reasonably confident that what he is seeing is bacterial and not fungal. In which case, if it's small and peripheral, because you have so many powerful fourth-generation fluoroquinolones now, it is possible to treat these patients generically without microbiology, provided the patient will follow up and the ophthalmologist has some experience in this region. Now, the important caveats to remember here are, if you have any doubt, it is better to do microbiology. And in the exam, it's probably better to say we will do microbiology, because as I told you earlier, the Arvind study showed that in Indian context, 50% of infections tend to be fungal, and the treatment of fungal and bacterial is so different that it is important to pick up the fungus if it is there right in the beginning. This is also emphasized by another study which was done again in Arvind, where they showed pictures of keratitis to 15 examiners both in the US and in India. And these experienced corneal surgeons looked at these pictures, and they were right in distinguishing bacterial from fungal keratitis only 2/3 of the time. So unless it's early, unless you have good examination skills and knowledge and experience, and you're confident that you've detected it's not fungus and it's bacterial, it is probably safer to get microbiology. So what do we mean when we say microbiology? Obviously, the most useful or the most simple thing to do is a corneal scraping. And in the exam, if they ask you how you would do it, it's important to say that you would do it at a slit lamp most of the time. You want to put in topical anesthetic with the patient seated at the slit lamp, and the anesthetic of choice is proparacaine because it is the least bacteriostatic. In order to get material from the cornea, you can use either a Kimura spatula, and it's special because it's made of platinum, and platinum can heat up and cool down very fast. Since you need a sterile instrument to take the scraping, the Kimura spatula can be heated red hot in a Bunsen flame. And then if you just wave it around for about 30 to 60 seconds, it cools rapidly, and then you can take things. On the other hand, if you don't want to be bothered with this, you can just use a disposable number 15 blade each of the time. Now, I don't know if the video is showing there. I hope it is. What I'm trying to show you is that you must take your scrapings like this with the blade held flat to the surface. You must not cut into this loose tissue because it's very easy to go through this necrotic tissue. and you must first remove all the mucous surface before you can take them. These scrapings are typically taken at the edge because this is where the organism is multiplying and spreading, and from the edge is where you get the highest yield. If you go to the center where it's more of necrotic material, not only do you not get these material that you take can be put into slides. Usually we take at least two, one for grams and one for KOH. And if you want to do a GM state, you need a third slide as well. We normally take cultures as well. And these are basically blood agar, Saburats dextrose agar, and material and put it on a slide. If you have a very thin smear, it's easy for the microbiologist to pick it up. And therefore, if you use your second slide 90 degrees away and smash the material, you will get two nice slides with thin layering of material, which the microbiologist can then stain and pick up the fungus. Then you take a second blade because the first blade contacted the unsterile slide. And the second blade is used to plate the agar in multiple Cs. C is typically used, and you use multiple Cs because if it grows only in one, it could be a contaminant. But if it grows in more than one of this, then we use blood agar for fungus, and we use Saburats dextrose agar. This does not contain cycloheximide, unlike systemic cultures. Okay, this is the Saburats dextrose agar slope that I'm plating. It contains cycloheximide for the systemic surgeons because they do not want the saprophytes or the ordinary commensals. But in the eye, we do not use cycloheximide because any fungus that you culture from a keratitis is considered positive or significant, and we don't have the concept of a commensal organism sitting on that area. We also like to use brain heart infusion broth as a liquid medium to increase the chance of finding the fungus. If you have a deep lesion which you cannot scrape from the surface, one of the ways in which we can get 80 silk or vicryl suture. It is important not to use nylon. We need a braided suture which has a rough surface, so either silk or vicryl. And then if you can carefully pass it through the cornea, going through the area of infection under the microscope, start to do this on the slit lamp. Then when you drag the needle out, the suture goes through this area of infection. Small bits of the infected cornea can get stuck to the sutures. You can then cut the suture with a sterile scissor into multiple tiny bits, which you can culture. You obviously can't get any smears from this approach. Sometimes in fungi, you find it in the posterior cornea on the endothelium like a plaque. And here you can use a 26 gauge needle, go into the chamber, go adjacent to this area of exudate, and carefully aspirate a small amount without collapsing the anterior chamber. And this you can then squirt either onto a slide or a culture plate for your analysis. If you treat the patient and he's not getting is not accessing it, then we do the biopsy. Biopsy is anesthetic, but you usually have the patient lying down under the mat. You do a freehand design, you can 3 millimeter the dermatology skin biopsy punches to mark the outline, and then you remove a disc of tissue which is about 30 to 50% in depth so that it includes the infiltrated tissue. You typically include a small area of normal cornea as well, so you can being as far away from the visual axis as you can. The sent for microbiology and the other is sent for histopathology. Very rarely we come across posterior stromal abscesses which are in the periphery near the limbus, and it's a unique approach that you can do a open the flap, and then from inside you can either drain the abscess or take material for culture, and then you can put the flap back and put a suture there, and these are the ways in which you can get tissue for analysis. Once you put it on the slide, you can do to look for fungi. Now this is the KOH mount, or the potassium hydroxide 10% mount, and this is the simplest, the cheapest, and the easiest way to do this. You just prepare potassium hydroxide from the pellets, put a few drops, leave it aside and have a look. You don't need the oil immersion. You can just look at it with a regular objective. And the idea here is that the potassium dissolves the rest of the cells, but not the fungus. And as you can see, the fungal filaments can be seen. You can also use chalcofluor white, which is basically a fluorescent dye which stains the fungal wall. But this requires special reagents in order pick it up. Third way to do it is what is called the GMS or the Gomonine silver stain, and you can see the still black here, the fungal filaments. Again, it stains the cell wall. But here again, you need the reagent, which is expensive.
Pardon, sir, your voice is not audible as of now.
Sir, we have lost your audio.
ऐसा इसका इलाज एक ही है। अगर वो आपको बोल रहे हैं फिजिकली है नहीं है, मैं आपको है ना ऑर्डर मतलब जो स्टॉक स्टेटस है ना, वो मैं ही आपको एक मेल पे लिख के दे देती हूँ।
The filaments can be.
Yes, sir. Now
they are 6 microns wide. They are about 200 to 400 microns long.
Sorry? Sir, pardon, sir. Sir, in between your voice was not audible in the earlier slide, sir. So if you can.
Want me to go back one slide?
Yes, sir. Yes.
Was it this slide?
You are showing, sir.
Hello?
Yes, from here. Yes, sir.
बाकी लोग को mute कर दे.
I'll go back from this slide in case it was not clear. So basically, once you pick up the material and put it on a slide, you have to pick up the fungus in it. And these are the ways in which you can do this. This is what is universally done in India. This is the potassium hydroxide 10% mount. The potassium hydroxide is very cheap, very easy to do, and a very quick method. You just make it from the pellets and then you put a drop in. It dissolves all the other cellular material and highlights the fungus that is present. This is chalcofluor white, which is a fluorescent dye which stains the fungal wall. But in order to do this, you need the special reagent and a fluorescent microscope. The third method is the GMS or the Gomonine methylamine silver stain. As you can see, it stains the elements black because of the wall. But this requires a reagent, it requires a gelatin-coated slide, and it requires 60 minutes of preparation time. Now, these two are more sophisticated methods. They are used generally in the West. The KOH has almost a 95% sensitivity and specificity in picking up the fungus, and it's better than these two methods in Indian conditions. Now, the other methods which are not used so often, I have put here. This is lactophenol cotton blue, which stains the cell wall of the fungus. And this is grams and GMSA, which only have about a 60 to 70% pickup rate. So these three are generally not used for the fungus. In the Indian context, this is the most important one, the KOH. But in the exam, you must also remember these two, and of course, lactophenol as well. The other method that has come into vogue in recent times with the advent of the confocal microscope and improvements in technology is using this device to look at the cornea and the 200. And although initial reports said that it was not so good, with the improvement in the confocal technology, current studies show that the sensitivity and specificity is about 80 to 90% in picking up the fungus in the cornea. It's especially useful in deep-seated infections where you can't get scrapes to get that particular material. And although there was a study which is branching angle and the pattern of septae, it is not possible. Another method. I think maybe the others can put their microphone on mute. Okay, thanks. So the other use the polymerase chain reaction, and this again has come into vogue recent times. It requires a very minuscule amount of material, as you know, and it's very fast. We target the fungal ribosomal DNA regions, either the 18S or the 28S rRNA primers, and the primers basically are used to pick up this presence of this particular genetic material and amplify it. So the way it is done usually is to use a pan-fungal primer, which is common to most fungi, and this will pick up and amplify any fungal infective DNA that is present in the sample that you give. And once you amplified it, then you can use more specific primers to sequence these particular amplified DNA, and this way you can also get a species result from this, which is very good because you can do this very fast. The one drawback is that it cannot distinguish between viable and non-viable fungi. It just tells you the presence of DNA, but it can't tell you whether the fungus is viable or not. So this is a downside. But for both the confocal and the PCR, obviously there's a cost involved. There's tremendous amount of equipment that is needed, and you need expertise to do this. So in general, although they are good techniques, we use them in cases which are challenging, where conventional methods have not proven to be of use, and we are stumped, and then you take recourse to this. And these are not definitely the first line of management. So in the exam, again, we will still stay with our smear and cultures, but it's good to know these options, because if they ask you what else can we do, then probably we can put this up. Fine. So you've taken material, you've done microbiology, you've picked up the fungus. How are we going to treat it? So the classes of antifungals, and there are only very few that we have. One of them is the polyenes. The important ones are natamycin, amphotericin B, and nystatin. We have the azoles, which have two categories: the imidazoles, which are the earlier generation, like miconazole, ketoconazole, sulconazole, clotrimazole, and iconazole, and the newer triazoles, which are the fluconazole, the itraconazole, the ravuconazole, the posaconazole, which is not freely available in India yet, and the oriconazole, which is. You also have what are called the allyl amines like terbinafine and naptifine, and the echinocandins like capsofungin and micafungin. But these four are not routinely used in the management of fungal keratitis. How do they work? The polyenes, like I said, target the ergosterol in the cell membrane of the fungus, and by damaging it, they're able to alter the cell membrane, which make it more permeable. So the intracellular contents leak out, and then there is cell death. The azoles, both the imidazoles and the triols, will inhibit the enzyme cytochrome P450-14 alpha demethylase. And here again, it targets the ergosterol because it prevents the conversion of lanosterol to ergosterol. So the building blocks are not available, the cell wall changes, and the organism is targeted. The allylamines and the echinocandins also work against ergosterol and glucan synthesis. So this slide is something that was used in the early days. This is the fifth category of agent that you can use against fungus, the antimetabolite 5-flucytosine, which halts nucleic acid synthesis, but it's way too toxic and therefore is no longer used. I put it here just for completion's sake if you're writing a theory paper. So as far as the treatment is concerned, some of the caveats are that the 5% natamycin suspension well against filamentous fungi, and it's the first choice in early fungal keratitis. The downside is that it penetrates the cornea very poorly, and newer water-soluble forms are being derived, which may be better. If they ask you in the exam about studies, basically we talk about the MUT trial, the mycotic ulcer treatment trial from the Arvind group in Madurai, which was the one that showed that when you compare natamycin with voriconazole, natamycin tended to be better in the treatment of fungal keratitis in South India, where the predominant infections were fusarium. The second agent that we use is something called amphotericin B. This is not available as a drop. It is a powder. It is used as a drop in 0.15 to 0.3 per brown bottle, or wrap the bottle with paper and make sure they don't keep it in light. It is a short shelf life of only about 3 days to 4 days, and it is written to the ocular surface, Candida and Aspergillus. One study the mustard fusarium, it doesn't generally not now the option for this. It can be used against and can be given orally as well. Fluconazole 0.2 to 2% works only against Candida. This is very important to remember, which means that it has really no role in fungal keratitis in the Indian context, where more than 97% are filamentous, against which this does not work. However, it has very good vitreous concentrations orally. So if you have an occasional patient with Candida endophthalmitis, then orally this can be used. Now, this is the way you prepare the amphotericin. You have 50 milligrams of the powder in a sterile hood. You can basically take 1/6 of the powder. You add distilled that is very important because nothing else, it precipitates with saline and all that. You add 5 ml of it, so this will give you the 0.15% strength. As I said, you dispense it in brown bottles, keep it protected from light, and constantly 3 to. Preparing a fortified medicine
Sir, your voice is not audible. We lost your voice.
is done in a sterile manner because you should not end up contaminating the drop when you're making it. Now, oriconazole fortunately comes in a kit where you can easily reconstitute it. Arvind does that, the oriconazole. And then basically you can also use oral medications like I told you. These are oriconazole 200 milligram twice daily, itraconazole 200 milligram, and oral fluconazole 150 milligram once daily. Posaconazole and caspofungin are not freely available or used in India at the moment. So in any infection in the cornea, apart from the specific antibiotic, you need cycloplegics to quieten the ciliary body. You need to manage the IOP because it goes up in a lot of fungal keratitis. Collagenase inhibitors like doxycycline can be used if you have stromal melting. Pain is an important component as far as the patient is concerned. And I mentioned steroids only to tell you that you must never use keratitis. The reason is the fungus tends to normally grow horizontally in the cornea parallel to the collagen lamellae. But if you use steroids, it has been shown that it can change its pattern of growth and migration to a vertical manner, which means it can go through the intact DM into the anterior chamber and proliferate there, making it harder to eradicate. And when it is in the anterior chamber, you'll get a very thick like I also get root signs that the fungus has reached the anterior chamber. So when the patient comes back with the treatment 2 days later, you look at his symptoms, you look at the signs, you look at the documentation that I showed you before to compare, and then you ask the patient about compliance to treatment. And at the end of this, you must label that patient as better, worse, or same. If he is better based on the parameters, and obviously it's all good, you just continue the treatment. The only thing is the tapering of the medication from 1 hourly to 2 hourly and so on is much slower in fungal keratitis than in bacterial keratitis. And in general, the treatment continues for 6 weeks because most of these antifungals just tend to stop the fungus from replicating, and the body's defenses is what gets rid of the fungus. So you need to give it some time. Most of these are toxic medications, so watch for toxicity. And another important point that you must remember is that epithelial healing in a fungal keratitis is not a bacterial keratitis. In fungal keratitis, you get a which the epithelium can grow. Unlike bacterial keratitis, where there's a loose melty stroma where the epithelium cannot grow and therefore healing is shown by epithelial migration. In a fungus, the epithelial healing is not to be taken as a sign of healing. But if you catch the patient early and if you treat it well, this kind of a fungal infection can respond well and you can get good outcomes. If the patient is the same based on your parameters, review his compliance, make sure he's using the drops correctly. And to me, I will only allow 3 visits 2 to 3 days apart where I still call it the same. After that, I feel he's worsening and you have to do something different. It's just that you can't pick it up. And when you believe he's worse, you can either consider a referral or a surgery. Sometimes the infection is under control, it's not spreading any further, but the loose melty stroma is not healing because the epithelium cannot grow and there's a lot of collagenase activity. So here, very rarely, you can use cyanoacrylate glue to try and quieten the surface because it seals it off, prevents the neutrophils and collagenases from accessing the stroma, and the eye can heal. However, the cyanoacrylate glue can interfere with visualization of what's happening in the cornea, and it interferes with the penetration of medicine. So it can be a double-edged sword, but in this case, it worked well and the eye scarred quietly. If the patient is definitely worsening and he is compliant to what you're using, in a bacterial infection, we take recourse to the antibiogram. Now, you can do antibiotic sensitivities for fungi, but it's a fairly special method. Most general labs won't do it. It's only available in tertiary institutions. And if you have it, you can use it to modify treatment, but most often you won't have it. If you feel that's another infection that has come in or something different is happening, you can redo the microbiology with the biopsy I talked about. Keep in mind medicamentosa and non-infective immune may exist which may prevent healing. But ruled out all this, this is the stage when it's getting worse, at which you must be starting to plan surgery. One step that you can do in surgery before you actually do corneal replacement is something that's recently come up, which is the injection of intrastromal and intracameral antifungals. This is the dose. Amphotericin stromal is 5 and 10, double that in the intracameral environment. And for oriconazole, it's 50 and 100 micrograms. How it works, in the cornea, maybe you're increasing the depot of drug in this stroma. In the anterior chamber, by making a paracentesis and washing the chamber, you're removing exudates, allowing fresh aqueous to come, and maybe putting a little bolus of antibiotic in. But be that as it may, sometimes it works. As in this particular patient, 18th of May, 21st of May, you can see it starting to spread here. This fungal therapy. So we gave him an intrastromal and an intracameral. Initially, you will see in the next day some increase in inflammation from your meddling, but over time, it tends to heal into a quiet little scar. So in some cases, these stromal and cameral injections do work. If you have a larger infection like this and you can see that it's positively getting worse and getting much deeper inside, then the other option is to straight away go ahead and operate. Therapeutic grafts are usually done and work best when you operate before the infection reaches the limbus. And sometimes you can get good anatomical as well as functional outcome, as in this particular case, but this doesn't happen all the time. Now, this is a flowchart that the AIMS group came up with. So this basically summarizes everything that I've been saying in the last half an hour. So you start with natamycin in most patients. Antibiotics, basically antifungals, deep keratitis, you and finish it. If he is not responding, then basically if you have in vitro sensitivity, you can change drug accordingly. If not, you can add aspergillus for amphotericin B or oriconazole if you think it's candida or aspergillus. And if it's fusarium, you can try the addition of oriconazole, although the much studies said it doesn't work so well. You can also try intrastromal or intracameral injections. And if it's not responding, then you go ahead with a penetrating graft. Some of the controversies in fungal keratitis is the use of surface cautery with heat or iodine. I generally don't do this. I don't think it should be done. And my rationale is that by destroying tissue, you're causing necrotizing tissue damage. And this is what the fungus will feed on. And therefore, and it works only on the surface. Therefore, in my treatment regimen, I do not have any role for these two. Repeated epithelial debridement is done to allow the drug to penetrate because the epithelium serves as a barrier for antifungal. One of the studies from Arvind showed that if you do this really, outcome finally in terms of vision tends to be worse, and therefore they generally don't believe in it, although some groups do. So it's controversial, which is why I put it on this slide. Conjunctival flaps try and work by bringing in some blood supply to heal the cornea. These are done in desperate emergency situations where you don't have access to corneal tissue, like in this lockdown phase now, when the eye banks are just starting to work. So in this situation, you may want to, but it's never the first line of treatment. DALC or anterior lamellar surgery is gaining a lot of popularity in keratoconus and so on. But again, in therapeutic corneal grafts, this must not be done. Because if you leave any stroma behind, it is likely that you could also leave fungal filaments behind, and then you can have a recurrence of infection. Collagen cross-linking and excimer phototherapeutic keratectomy to remove the tissue is not done anymore. Collagen cross-linking has been shown to make things worse. And PTK only works for the most superficial infections where natamycin would do an even better job. So lastly, the last few slides, as I'm reaching the end of my 45-50 minutes, is to talk about Pythium keratitis. Pythium insidiosum was generally reported in veterinary animals. Basically, it causes infections and there was no real antibiotic to it. So they basically used to amputate again and again until they got rid of the infection completely. It's almost like gangrene. It has fungus-like features. It has broad, sparsely or aseptate filaments which have ribbon-like folds. And the reason why the antifungals don't work is because it does not contain ergosterol in the cell membrane. So it's classified as a fungus of uncertain etiology. It has some relation to the kelp and the water plants that you see on the show. Under the water, you see those broad, wavy green plants. It has some bearing with that. And this was the outcome in the initial days before we truly understood it. Basically, you would have infections spreading, you would try and operate, it would come back again, you would operate again, it would come back yet again, and most of these eyes underwent evisceration. Until we slowly realized that this organism has beta-glucan as well in the cell membrane, and the group at LV Prasad found target the beta-glucans, and so now we can manage it slightly better. So when you do a KOH, you see the filaments with sparse septate, and these are the broad ribbon-like folds. So this looks on casual examination like a filamentous fungus itself. So you need to be aware and have a high index of suspicion to detect it. This is the blood agar growth at and today we also look at it by PCR because of the sequencing. The typical findings of the infiltrate, it has these kind of reticulated tentacle-like edges, and you can see these pinhead-sized infiltrates spreading out of the main body of this. And most of these are seen best when you dilate the pupil and retroilluminate. You can see this tentacle-like spread in the surrounding stroma. And another classical finding is the peripheral furrowing. You can see it starting here, and you can see it more extensively here. So these are the findings that are typical of Pythium keratitis. But in general, at the beginning, it resembles a fungal keratitis. So when you see something that looks like a fungus but doesn't respond typically like you're normally used to seeing the response, then you think Pythium, and therefore you need a high index of suspicion. As I said, antifungals that we use work on ergosterol. This does not have ergosterol, so these cannot work. So we target the beta-glucan in the cell membrane. And linezolid is one of the things that can help. So you can use 0.2% linezolid drops. You can use 1% targets the macrolides do that. You can use oral azithromycin in the most severe cases. And during surgery, the group from Shankar Netralia showed that if you use absolute alcohol for a contact time of up to a minute, and then if you do double freeze thaw cryotherapy to the edges, then your risk of getting a recurrence can be minimized. So my last slide. So fungal keratitis, I've tried to take you through a story which hopefully is important for you from the exam point of view, and I've tried to cover topics that I thought might be useful. So remember microbiology. In the exam, this is important, the smears and the cultures, how you do them. And from the clinical point of view, the earlier you recognize the fungus, the better you can treat it. Like I told you before, you need to remember the classification as filament, septate, aseptate, pigmented, non-pigmented, and the various categories of antibiotics, and try and mix and match them. So if you put fluconazole in a filamentous fungus, you're going to help it at all. And obviously, we don't use steroids. Surgical therapy is needed in approximately 1/3 of these patients, despite appropriate and adequate medical therapy, and therefore you must be prepared to operate. Surgery does have good success in saving the eye. In about 75% of therapeutic TKs, we can save the eye, but visual outcomes are good only in about 1/3 of these. And today, we must always be aware of Pythium because it can mimic fungal keratitis very closely, and unless you have a high index of suspicion, you're most likely to end up missing it. Good. So I think that was my last slide. I think I stayed within my 45 or 50 minutes that I was given. So thank you very much, and all the very best for your exams.
Thank you so much, sir, for that amazing presentation. What a blessing it's going to be for the postgraduates. Even before their exams, they can just revise through this presentation and just go and appear in the exam. What a wonderful presentation it was, sir. Thank you so much for your presentation. Sagar, you are there? Sir, one question is there, sir. Why do we make C pattern on the culture plate, sir?
Yes, please. Go ahead.
Sir, why do we make C pattern on the culture plate?
Yeah. Basically the C pattern, the curve gives you the maximum area of contact of the material with the culture plate, as opposed to linear streaks and so on. The curve gives you maximum area. And then when you make culture plates contain the fungus as a contaminant. So it may randomly grow here or there. So if you just make 1 or 2 streaks, it may actually match one of the streaks that you have put in, and you have a doubt whether it's from your smear or whether from the plating that you did, or whether it's a contaminant. So if I make 9 Cs, then if it is present in the blade that I was using to inoculate, it will grow in at least 7 or 8 of these 9 Cs, and then I'm more confident that the fungus that is growing is what I took from the patient, rather than from a random growth on the plate. And that is why we use the Cs.
Sagar?
Yeah. This is Sagar. Wonderful talk from you, and refresh my memories back 15 years back in Shankar. I missed your presentation in bacterial infection. situations? How do we identify them? How do we approach them?
You're breaking up. I got the last bit. How do you identify what?
Superimpose bacterial infections, sir. Bacterial infections.
Yes. So basically, it's a good question, Sagar. Hi. The question is, how do you deal with mixed infections when you have a bacterial and a fungal component? So there can be two ways in this whole thing. First thing could be that you have an infection that you see, you're treating it with antibiotics, it seems to be responding very well and you're very happy. And then after about 4 or 5 days, the infection again starts to spread. So this is one scenario. So this is a context where you have a fungus and a bacteria. The antibiotic gets rid of the bacteria, everything seems to be healing. In the background, the fungus is growing more slowly, and after 4 or 5 days, he starts to show up. So here you started off thinking it's bacteria, and then you treat it, and then you end up with a fungal component. The other scenario is that you think it's fungus and you're treating it as fungus, but there's also a hidden bacterial component, and that starts to slow down the healing or starts to show up again. That is why I said, when you have a patient, when you're re-evaluating him on subsequent visits, if for 2 or 3 visits you think he is same or he is worsening, you have to ask why. So either the fungus or there's another component to the, and this is where you generally take recourse to a biopsy. Ideally, you stop your antibiotics for 24 hours to give the organism a chance to grow, and then you subject it to a deeper biopsy, and this will go both for histopathology and for microbiology to see if there's any other organism which is coexisting, which is not responding to the antifungal and making things worse. You can also have Acanthamoeba coexisting. And in some centers, where you get a smear, where it's a fungus, they don't like to use antibiotics. They want to use only antifungals. But this is controversial. I, for instance, even if I have a fungal infection, I will cover it with an antibiotic as well, because I'm worried about a secondary infection.
Okay. So there is another question. Why do we need to take normal tissue in case of corneal? Is a question to you, sir. Normal corneal tissue.
Why do we need to take
normal tissue?
Because yes, I got the question. I think basically because I told you that one biopsy is going for histopathology, the other one is going for microbiology. Because you're doing this, since you don't have an idea as to what is going on, the patient is not responding. So when you take the trouble of taking him to the theater and doing this whole exercise, you want to get the maximum information. So you will also send it to histopathology. So when you send it to histopathology, when they make the section, so if they have normal cornea on one side and the infected cornea on the other, the chance of them picking up the infective agent is much greater because the organism is obviously spreading outwards into the normal cornea. Histopathology on the section, if they can see both, it's much easier for them to pick up an organism there. So that is the reason why you go through this. And also, it is safer for you because when you're taking the tissue, when you're working in the normal area, that is where you can go to the correct depth and then advance into the infected area. In the infected area, everything is loose and pouting and melty. So if you try and cut through that area to start with, it's not very difficult to go through that area and end up with a perforation. So for these two reasons, one, the ease of excision, and two, for the histopathologist to be able to tell you what is there at the junction between infected and healthy tissue, you try and include a small bit of the normal tissue as well.
Right, sir. So there is another question, sir. Why are the margins of the infiltrates hyphenated? And is there any specific reason for satellite lesions? Satellite lesions, sir. The satellite infiltrations.
Why are the margins hyphate and why are they satellite? I think you broke up in between, but I think this is the question. So basically, it's because of the way the filamentous organism grows. You will not see this pattern in a yeast. A yeast forms a very rounded, localized inflammation, which is more wet. Whereas these are saprophytic organisms which are trying to spread out and get it more nutrition. So the way the hyphate edges represent the way the filamentous fungi branch out. And satellite lesions are because they grow in the lamellar, between the lamellae of the cornea. So it is not very difficult for them to grow in the lamellae and then end up causing a second infection a little further ahead. However, even though we talk so much about this, and in the exam, you cannot basically pass if you don't mention satellites and hyphae in a fungal infection. There are studies that show that these typical findings of satellites are only seen in about 10 to 20% of filamentary fungal infections. But it was described earlier, and when you do see it, obviously it is fungus most of the time. But if you don't see it, I don't think you can use it as a negative finding and say, oh, this is not fungus because there are no satellites. So it only occurs 10 to 20% of the time. But in the exam, I think if you want to pass, you must mention it.
There's one more question, sir, with Dr. Kapil. He wants to know the protocol treatment for deep corneal infections. Yes, sir. Deeper corneal infections.
Basically, I guess you first try and figure out what infection it is. Today we are talking about fungal keratitis, but it could be other organisms as well. So we did talk about, when we talked about the biopsy methods of how you can access deeper corneal tissue as well. So ideally, you want to get an idea or get a handle on what the infection is, and then you start treating it with the appropriate antibiotic. The importance of a deep infection is that many times the drug does not penetrate through the cornea and reach those levels, particularly with the antifungals. So in that context is when, if you see it is deep and if you find that it is trying to spread, that the intracameral injection, if it is in the deeper cornea, and an intrastromal injection, if it's in the deep intracameral injection, it's all back of the cornea. I'm not saying that they work all the time, but it's worth giving it a try because it avoids the more invasive therapeutic corneal grafting as a first option. But if you've done all this and it continues to keep worsening, then I guess you will go in with a surgery. So the principles of treatment remain the same. It's just that there is less reliance on topical antibiotics in a deep corneal infection, particularly in a fungus, because we know they don't reach there as well.
Okay. So, thank you, sir. Another one interesting question is, on the patient's first visit, if we don't see the posterior segment, would we do a B scan, ultrasound in case not able to see the fundus on day one? Can it be done?
It can be done. There is no harm in doing it because the patient has his eyelid closed. So the only concern is about contaminating the probe, but that can be very easily disinfected. But having said that, if you've had a penetrating injury with a thorn or something and you're worried that it has gone through, then the risk of it having spread to the back right on day one is very high. But a normal fungal keratitis from a superficial trauma to the cornea, for it to spread deep into the AC, then go past the lens in a phakic, go past the zonules and into the vitreous, it takes a very long time. I'm not saying it cannot happen, but it takes a very long time. It is very unusual. So either during surgery, you must have lost the lens and then you've seeded it into the back, or the initial trauma was penetrating and went into the back and carried the fungus there. A corneal infection per se, a fungal infection, for it to go into the AC, past the iris, past the zonules and lens and into the vitreous is extremely rare. But if you have a very dense corneal infiltrate right in the beginning, particularly if it has inaccurate projection of light, I see absolutely nothing wrong in getting a B scan done to ensure that the posterior segment is all right. But if you have a 1/4 corneal infection, you can just as well dilate and have a look at the fundus if you like, no problem at all.
Great. Thank you. There's one more question. The number of days you would systemic fluconazole. How many days would you recommend for treatment?
You have to repeat it. My connection's going back and forth. I completely lost the question.
They basically are asking, sir, how many days would you recommend systemic fluconazole?
Systemic therapy.
How many days? Yes, sir.
Yeah, systemic therapy basically has to be taken with a pinch of salt. Like I said, the protocol from All India Institute recommended it if it was have an endophthalmitis, systemic therapy is essential. But if you have a pure corneal infection, the extension to the MUT trial did not show much benefit in adding oral oriconazole to the topicals. So that is to be taken first. If you believe the data from literature, maybe there is not much use in using it. But if you do have a very severe infection and you feel that there might be some added benefit and therefore you're going to give the benefit of doubt to the patient and use it, normally we use it for a week to 10 days. But here I will want to add that it will not be fluconazole. Like I told you, 97 to 98% of infections in the cornea in India are filamentous, against which fluconazole has virtually no action at all. So I am talking about oral voriconazole, or if the patient cannot afford it because it's very expensive, we use oral itraconazole, because these are the two agents that work to some extent against the filamentous organism. You only use oral fluconazole if you have a vitreous involvement and if you think there's an endophthalmitis caused by candida organisms or the yeast forms, then you can consider the oral fluconazole.
Okay. Most of the questions are over, sir. There is a question. How many days do we need to wait to call a culture negative in case of a fungal keratitis? How do we tell the patient is negative of infection? That's the question, sir.
Most fungi
yes,
will grow within 72 to 96 hours. Most fungi will grow within 72 to 96 hours. Labs generally keep the cultures for 3 to 4 weeks before discarding them, but typically fungi will grow pretty fast, particularly if you've taken the blood agar, the saburaj agar, and the BHIB like we talked about. So unlike organisms 5 weeks to 3 to 4 weeks to grow, most fungi will grow within the first 3 to 4 days. So if you still have a doubt, you can always go ahead with the PCR, because that will give you a very rapid presence of the fungus will be identified.
Right. Another interesting question, sir. Do we avoid tear lubricants during the treatment of fungal corneal ulcer? You had mentioned about medicamentosa, so tear lubricants probably will add or will kind of help in some way.
I'm very sorry, my connection's not particularly great.
Sure.
You're asking about tear substitutes.
Yes.
Yeah. So there are two contexts that I want to answer this question in. One is just the routine tear substitute. Do I want to use it? Probably not. I don't think it has any role. And if you give the patient unnecessarily more and more drops, basically he will end up using the wrong one and miss the important one. The other context is about formulating medications. A lot of people just take whatever tear substitute they have and put some of the powder into it and they mix it and give it. Particularly for ampho-B, it will not work. So if you want to dispense amphotericin B as a drop, you have to use distilled water. Do not use any of the available tear substitutes as your diluent, because the bioavailability of the amphotericin when you constitute it that way will not be adequate. But if you're asking, should I just put a teardrop on the patient's eye who has an infection of fungal keratitis, I think the answer is no. It has no logic or relevance, or it may end up basically adding more drops to the patient's regimen, and he may not be following your protocols then.
I think question.
Thank you so much, Dr. Sagar, for that beautiful moderation.
Good. Thank you.
Once again, I would like to thank Dr. Srinivas Rao, who I told in the beginning, if some of the postgraduates missed listening to me, sir is an absolute living legend, and you can we will request sir in future also to take a few more classes. What an interesting class it was. Everybody can revise this fungal keratitis. I think I have already learned so much today. We have had so much revision today, and it will be so helpful for the postgraduates. Tomorrow we have a class on corneal dystrophy and interstitial keratitis. Corneal dystrophy will be by Dr. Rajesh Fogla, and interstitial keratitis will be by Dr. Sumana Chatterjee, and it will be moderated by Dr. Mamta Singh, who is online right now also. She is with us, and also she is a consultant at the Regional Institute of Ophthalmology, IGIMS Patna. Thank you so much, sir, once again. If we have some questions, I'll send it to you on the email from the postgraduates. But I would like to thank all the postgraduates also who were here with us this evening. We'll see you again tomorrow evening. And there are more hundreds and thousands of hits on the YouTube to see this program around the world again and again. So many postgraduates around the world are going to be benefiting by this such a exclusive, detailed fungal keratitis talk. Thank you so much, sir. Thank you so much, sir, for your time, effort, and your blessings to the postgraduates, sir. Thank you, sir. Thank you, Dr. Sagar, for your time. Thank you so much.
Thank you. It was a wonderful class. Thank you so much.
I would like to thank Intas Pharmaceuticals for taking so much effort in organizing all this. Manish ji, Chandrasekhar ji, thank you so much for your effort in bringing this all together. Thank you so much.
Thank you, sir. Thank you, sir. Welcome, sir.